You know that feeling, right? When you're staring down a critical exam or maybe heading into a challenging clinical shift, and you just need to get a complex topic like cardiovascular assessment. Not just memorize it, but really understand the moving parts, the why behind it all. Welcome to the deep dive. We're here to cut through the noise and unearth the most vital insights from dense subjects. Today, our mission is a comprehensive deep dive into the assessment of the cardiovascular system. We're pulling the key stuff from Lewis's Medical Surgical Nursing, a really foundational text for future nurses. Our goal isn't just to tell you what to assess, but to arm you with the critical thinking needed for real-world patient care and those tricky NCLEX questions. To make this journey super practical, we're going to follow LP. He's a 63-year-old man who landed in the hospital reporting chest tightness, shortness of breath, and palpitations. His story will be our guide, helping us connect every piece of theory directly to practice. So, what's our game plan? We'll first explore the absolute essentials of heart structure and function, then how age changes things.
After that, we'll move into the critical steps of subjective and objective nursing assessments, get a peek inside with hemodynamic monitoring, and finally look at the diagnostic tools that give us even deeper insights. Okay, let's unpack this. Before we can even begin to spot problems, we need a crystal clear picture of what a normal, healthy heart is doing. So where should we start our dive into the basics?
Absolutely. Let's start simple. Think of the heart as your body's remarkably efficient, four-chambered pump. It's about the size of your fist. Its main job, keep blood moving. And it does an incredible job, really. Structurally, the key layer to remember is the myocardium, that powerful muscular layer. That's the workhorse. You'll notice the left ventricular wall is significantly thicker than the right. Why?
So that has to pump blood to the whole body, right? More work.
Exactly. Yeah. It needs that extra strength. And the blood flow follows a precise one-way journey from the body into the right side, off to the lungs for oxygen, then back to the left side, and finally pumped out to the rest of you. The four valves, mitral, tricuspid, pulmonic, aortic, they act like one-way doors,
Keeping everything flowing in the right direction.
Precisely. Now, this powerful muscle needs its own blood supply. That comes from the coronary arteries. And here's something fascinating, often a surprise. These arteries get most of their blood flow during diastole.
During relaxation, not when it's pumping hard.
That's right, when the heart muscle relaxes. The two main players are the left coronary artery, which branches out quickly, and the right coronary artery. Why does this matter beyond just anatomy? Well, for about 90% of people, that right coronary artery also feeds key parts of the heart's electrical system, the AV node and bundle of His.
Okay, so a blockage there isn't just muscle damage.
It can really mess with the heart's rhythm, cause serious conduction issues.
So it's like a dual-purpose artery.
Yeah.
And speaking of rhythm, the heart doesn't just pump mechanically, it has its own electrical spark. How does that work?
Exactly. The heart has this built-in electrical system, kind of like wiring. It generates and spreads an impulse. It all starts at the SA node, the heart's natural pacemaker. From there, the signal travels a specific pathway, hits the ventricles, and triggers that synchronized, powerful contraction. This electrical process has two phases: depolarization, which leads to contraction, and repolarization, which is the resting and recharging phase.
And we can actually see this electrical activity, right? That's where the ECG comes in.
That's it. The electrocardiogram, or ECG, is our window into this electrical show. You'll see those familiar waveforms. The P wave, that's the atria contracting.
Okay.
The QRS complex is the ventricles contracting powerfully. And the T wave shows the ventricles relaxing and recharging. Changes in the timing between these waves, like the PR or QT interval, can hint at underlying problems.
Gotcha. So electrical drives mechanical.
Right. The electrical signals drive the mechanical action. Systole is the contraction phase, pushing blood out. Diastole is the relaxation phase, when the ventricles fill up. The amount of blood pumped by each ventricle in 1 minute. That's cardiac output, CO. And it's simply your stroke volume, SV, the amount per beat times your heart rate, HR.
And what's normal for an CO?
For most adults at rest, we're looking at about 4 to 8 liters per minute.
4 to 8 liters a minute. Wow, that's impressive. What factors really make that CO number go up or down?
Great question. CO is ecstatic. It's a delicate balance. Your heart rate obviously plays a big role. If it's too fast, the ventricles don't have enough time to fill properly, and that actually cuts CO. Then there's preload. Think of it as the volume of blood stretching the ventricles right before they contract, like filling a balloon.
The more stretch.
The more forcefully it snaps back, exactly, up to a point. Things like hypertension or just fluid overload can increase preload. Dehydration reduces it. Contractility is the actual strength of the heart muscle squeeze. Some meds boost it, others reduce it. And finally, afterload. That's the resistance the heart has to pump against. Imagine the pressure in the pipes your pump is pushing water into.
So high blood pressure would increase afterload.
Significantly. It makes the heart work much, much harder. Your body also has built-in regulation systems. The autonomic nervous system is constantly fine-tuning. Sympathetic speeds things up, constricts vessels. Parasympathetic slows the heart down. You also have baroreceptors in your arteries sensing pressure changes, telling the brain to adjust BP up or down.
Like little pressure sensors.
Exactly. And chemoreceptors monitor oxygen and CO2 levels, signaling adjustments if needed. It's a really sophisticated system, all designed to maintain your blood pressure, which is simply the force of blood against your artery walls. We measure systolic BP, peak pressure during contraction, and diastolic BP, residual pressure during relaxation. A really crucial number for nurses is mean arterial pressure, MAP. That's the average pressure keeping your vital organs perfused. Ideally, it needs to be above 60 millimeter Hg.
That's a really solid foundation.
Mm.
But knowing normal is just the start, right? What happens when the heart ages? Our patient LP is 63, so age is definitely a factor here.
You're absolutely right. Age is actually the single biggest risk factor for cardiovascular disease. For LP, several age-related changes are likely relevant. First, his heart muscle itself might become a bit stiffer, less elastic, might not respond as quickly to stress. Think of like an older rubber band.
A snapback.
Exactly. Secondly, his heart valves, especially the aortic and mitral ones, can thicken and stiffen. This often leads to murmurs, those sort of whooshing sounds, as blood flow isn't quite as smooth. Also, the electrical system can see a decrease in pacemaker cells. This puts older adults at higher risk for dysrhythmia's irregular heartbeats. It can even show up on an ECG as, say, prolonged intervals.
Okay.
And finally, the blood vessels themselves thicken and lose elasticity. This often contributes to higher systolic blood pressure and can impact how his body regulates pressure overall. This can lead to things like orthostatic hypertension, that dizzy spell when you stand up too quickly, or even a drop in blood pressure after eating. Both increase the risk of falls, which is a big concern.
These age-related changes are incredibly important context for LP's situation. Okay, now let's talk about the first and arguably most important part of any assessment. Simply listening to the patient, the subjective data.
This is where we gather subjective data, the patient's story. It's absolutely key. We start with the history of present illness, what brought them in today. For LP, we'd be digging into his chest tightness, the shortness of breath, the palpitations. When did they start? What makes them better or worse? Was the onset sudden? We also need his health history. Has he had angina before? Hypertension, diabetes, heart failure, all crucial pieces for LP.
And his medications, right? Even OTC.
Definitely. Prescription, OTC, even herbal supplements. It's surprising how many non-cardiac drugs can actually impact the heart. For instance, some antipsychotics can cause dysrhythmias or that orthostatic hypotension we mentioned. Even common NSAIDs can increase the risk of heart failure exacerbations. We also look at his functional health patterns. How does his heart health impact his daily life? We'd ask about major cardiovascular risk factors. He might have hypertension, diabetes are already on his list. Family history of early heart disease.
What about activity?
Yeah, does he get chest pain or shortness of breath with exertion? For sleep, does he ever wake up gasping for air that's paroxysmal nocturnal dyspnea, or need to sleep propped up on pillows, which is orthopnea? Those are huge red flags, often pointing towards heart failure.
And you mentioned straining earlier.
Yes, a critical teaching point, especially for anyone with heart issues. For elimination, we want to make sure he's not straining during bowel movements. That Valsalva maneuver can put a lot of stress on the heart. Finally, in terms of sexuality, sometimes we need to ask about things like erectile dysfunction. It can be an early sign of peripheral vascular disease or sometimes a side effect of common heart medications. And a huge safety point. If a male patient is taking ED drugs like sildenafil, they absolutely cannot take nitrates. That combination can cause a severe, dangerous drop in blood pressure.
Wow, that's a really comprehensive picture just from listening and asking the right questions. Let's bring LP back into focus now with his specifics, subjective data. Okay, so LP is 63. History includes hypertension, mitral valve prolapse with mild regurgitation, heart failure, and type 2 diabetes. His meds are lisinopril, metoprolol, aspirin, furosemide, and glipizide. He reported waking up with shortness of breath, chest tightness, and palpitations. He actually thought he was having a heart attack. The SOB and chest tightness resolved on their own,
But the palpitations, they stuck around. He denies smoking, alcohol use, edema, or waking up at night to urinate, and he knows he takes his furosemide in the morning.
Okay, given LP's history and these current symptoms, his report of new onset chest tightness and shortness of breath are concerning, but it's the persistent palpitations that really jump out as an immediate red flag. His history of heart failure and mitral valve prolapse means his heart already has some known issues, some vulnerabilities.
So the palpitations sticking around is the big clue here.
Yes, the fact that they're persisting after the other symptoms resolved strongly suggests an active electrical issue. For a nursing student, your mind should immediately go to, okay, what's happening with his heart rhythm, and how is this affecting his heart's ability to pump effectively? This interplay between his chronic conditions and these acute symptoms is exactly what we need to connect.
Right. We've heard LP's story. Now it's time for the objective data, what we can actually observe and measure ourselves.
Exactly. This is the hands-on part. We start with his vital signs, naturally. Always measure BP bilaterally, at least initially. We'll also perform orthostatic vital signs. That means checking his BP and heart rate while he's lying down, then sitting, then standing.
Looking for that drop in pressure or jump in heart rate.
Precisely. A systolic drop of more than 20 mmHg or a heart rate increase of more than 20 BPM from lying to standing signals orthostatic hypotension. For the peripheral vascular system, we inspect his skin color, temperature, hair distribution. We check carefully for any swelling or edema in his legs, and we specifically look for jugular venous distension, JVD, in his neck veins while he's semi-reclined, maybe 30-45 degrees. JVD is a key sign of increased pressure on the right side of the heart, often seen in right-sided heart failure.
Okay. And palpation, what are we feeling for?
We'll palpate his pulses, radial, brachial, pedal, etc. in both arms and legs, comparing them side to side, grading their strength. We check capillary refill time in his nail beds. We'd also listen with a stethoscope bell over his carotid arteries for bruits, that sort of whooshing sound caused by turbulent blood flow, often indicating narrowing.
Makes sense. And then moving to the chest itself.
Moving to his chest, we first locate the key areas for listening to heart sounds: aortic, pulmonic, Erb's point, tricuspid, mitral. We also palpate the chest wall for any heaves, which are like sustained lifts that can indicate an enlarged ventricle. Then comes auscultation, the listening part. We're listening for the normal S1, the lub, when the mitral and tricuspid valves close at the start of systole, and S2, the dup, when the aortic and pulmonic valves close at the start of diastole.
Lubbed up, lubbed up.
Exactly. And a really critical skill here is to simultaneously palpate the radial pulse while listening to the apical pulse right over the heart. If the amical rate is significantly higher than the radial rate you feel at the wrist, that's called a pulse deficit. It often indicates dysrhythmias where not every beat is strong enough to reach the periphery, like atrial fibrillation.
Ah, that's a key connection. What about extra sounds?
We listen carefully for extra sounds. An S3 heart sound, sometimes called a ventricular gallop, often indicates decreased ventricular compliance commonly heard in heart failure. An S4 heart sound, or atrial gallop, suggests forceful atrial contraction against a stiff ventricle. And of course, we listen for murmurs. These are turbulent sounds usually caused by valve problems, like LP's known mitral regurgitation.
Okay, so let's tie this back to LP. He had palpitations, a known systolic murmur, and an irregular apical pulse subjectively. Now, the objective findings. LP's BP was a 1 down 5, 4. His apical pulse was rapid or 154 and irregular. Respiratory rate 20, O2 set 94% on room air. He was alert, lungs clear. That systolic murmur was present. Critically, his heart monitor showed atrial fibrillation with a rapid ventricular response, AFib with RVR. He had +1 pedal pulses bilaterally, but no peripheral edema, no JVD, and no heaves were noted.
Okay, this is where it all crystallizes. LP's low blood pressure of 1 TN54 combined with that very rapid and irregular apical pulse of 154 and the confirmed AFib with RVR on the monitor, these are immediately concerning.
Because the heart's beating too fast and chaotically.
Exactly. It can't fill properly between beats, and it can't pump effectively. This leads to a drop in cardiac output, which explains his low BP and likely his earlier symptoms. The systolic murmur fits with his known mitral valve issue. For a nursing student seeing this, the absolute priority is stabilizing his heart rate and rhythm. His current state means his vital organs aren't getting optimal perfusion. He could decompensate quickly.
So sometimes we need an even closer look inside.
Yes, especially in critical care. That's where hemodynamic monitoring comes in. It allows us to measure pressures, flow, and oxygenation within the cardiovascular system. It helps assess heart function, fluid balance, and how the patient is responding to treatment. Key measurements include cardiac output, CO, and cardiac index. CI just adjusts CO for the patient's body size, making it more personalized. We also look closely at preload, that's stretching volume in the ventricle. We estimate left ventricular preload with pulmonary artery wedge pressure, PWP, and right ventricular preload with central venous pressure, CVP, and afterload, that resistance the heart pumps against. We measure systemic vascular resistance, SVR, for the left ventricle. Increased afterload means more work for the heart, more oxygen demand.
And getting these measurements requires careful setup.
Right, absolutely. For invasive monitors, precision is key. We reference the transducer, the part that reads the pressure to the phlebistostatic axis. That's an imaginary point on the side of the chest, level with the atria. A huge safety alert here. If the transducer is positioned too high, you'll get falsely low readings. Too low, and you get falsely high readings. Accuracy matters.
Makes sense.
We also zero the monitor to atmospheric pressure before taking readings. Common types of invasive monitoring include arterial BP monitoring. This gives continuous beat-to-beat readings of SBP, DBP, and MAP. It's essential for critically ill patients, especially those on medications that affect blood pressure.
What are the risks with arterial lines?
Big nursing responsibility here is monitoring for complications. Hemorrhage is one, infection is another. But a major one is neurovascular impairment to the limb where the line is inserted, usually the radial artery. That's why before a radial arterial line is placed, we always perform an Allen test to make sure there's good blood flow from the ulnar artery, just in case the radial gets blocked. Checking circulation distal to the site is crucial post-insertion.
Got it. What about the Swan-Ganz?
Right, the pulmonary artery catheter, often called a Swan-Ganz. This gives us those key PA, WP, and CVP measurements, which are vital for assessing fluid status and heart function, particularly in complex heart failure or shock. During insertion, constant ECG monitoring is critical because manipulating the catheter in the heart can easily trigger dysrhythmias. The absolute takeaway for nurses using any hemodynamic monitoring is this: always correlate the numbers on the screen with your actual patient assessment. Look at trends, not just single numbers. Treat the patient, not the monitor.
Okay, we've assessed the patient, gathered subjective and objective data, maybe even got some hemodynamic numbers. Now, what tools help us confirm our suspicions and really guide treatment?
This is where diagnostic studies come into play, ranging from simple blood tests to complex imaging. First up, blood studies. When heart muscle cells are injured or die, like in a heart attack, they release specific proteins called cardiac biomarkers into the blood. The gold standard test for diagnosing cardiac injury, like an acute coronary syndrome or heart attack, is cardiac-specific troponin. Specifically, troponin T and troponin I, CTNT, CTNI.
Right, troponin.
Because it's highly specific to heart muscle. Levels start to rise within about 4 to 6 hours of injury, peak later, and stay elevated for days, which gives us a good window for detection. High-sensitivity troponin assays can detect it even earlier now. Another important marker, especially for heart failure, is BNP, or B-type natriuretic peptide. The ventricles release BNP when they're stretched, like in fluid overload or heart failure.
So high BNP points towards heart failure.
Yes. A high BNP is a strong indicator. It's incredibly useful for helping distinguish if a patient's shortness of breath is primarily due to a cardiac issue versus, say, a respiratory problem like COPD or pneumonia. We also routinely check serum lipids, things like total cholesterol, LDL, bad cholesterol, HDL, good cholesterol, and triglycerides. These are key risk factors for developing atherosclerosis and coronary artery disease.
Let's check back in with LP's diagnostic results then. Okay, LP's initial lab orders included a 12-lead ECG, CBC, BMP, which includes electrolytes like potassium, coagulation studies, PDPT-TNR, pro-BMP, troponin CKMB, thyroid tests, and a chest x-ray. His results came back. The ECG confirmed AFib with RVR. His troponin and CKMB were normal. His potassium level, however, was low at 3.1 MEQL, and his pro-BMP was significantly elevated at 1204 PGML. Other labs were normal. Based on this, the provider immediately ordered a normal saline IV bolus, oral potassium supplements, an IV diltiazem loading dose, followed by a continuous infusion and weight-based heparin.
Okay, these results paint a very clear picture, and they really explain LP's condition. His normal troponin effectively rules out an acute heart attack, which is great news. But the AFib with RVR on his ECG confirms the chaotic electrical activity we suspected from his symptoms and irregular pulse.
And the high pro-BNP.
The significantly high pro-BNP way up at 1204 basically screams acute heart failure exacerbation. This explains his shortness of breath, his heart is struggling to cope, and that low potassium of 3.1 is critical here. Hypokalemia can make the heart muscle even more irritable and can worsen or even trigger dysrhythmias like his AFib.
So the interventions make sense now.
Absolutely spot on. The IV diltiazem is a calcium channel blocker used specifically to slow down that rapid ventricular rate in AFib, letting his heart beat more efficiently. The heparin is crucial because AFib significantly increases the risk of blood clots forming in the atria, which could lead to a stroke. Heparin helps prevent that. The oral potassium directly addresses that dangerous hypokalemia, aiming to stabilize his heart's electrical activity. The normal saline bolus might seem a bit counterintuitive with heart failure, but perhaps his BP was low enough they wanted to support it initially, though fluid status will need very careful monitoring now.
That really shows how diagnostics drive the treatment plan.
Exactly. It's classic critical thinking in action, connecting the symptoms, the objective findings from your assessment, and the lab results directly to targeted nursing actions and medical interventions. Beyond blood work, we have other tools. Electrocardiography isn't just the 12 lead. It includes things like Holter monitors patients wear for 24-48 hours to catch intermittent rhythm issues. Functional studies, like exercise stress tests, push the heart under controlled conditions to see how it responds to physical demand.
What about imaging? Seeing the heart.
For imaging, a basic chest x-ray is often a first step. It gives us a quick look at the heart's size and shape and can show signs of fluid in the lungs, like pulmonary edema in heart failure. An echocardiogram is a huge one. It uses ultrasound waves to visualize the heart's structures, how the valves are moving, the size of the chambers, how well the walls are contracting. And critically, it measures the ejection fraction, EF, which is the percentage of blood pumped out of the left ventricle with each beat. It's a key indicator of systolic heart function.
And sometimes they do a TE?
Right. A transesophageal echocardiogram, TE. This provides even clearer images because the ultrasound probe is placed down the esophagus right behind the heart, bypassing the ribs and lungs. It does require sedation, though. For looking specifically at the coronary arteries, cardiac CT scans, especially coronary CTA, offer a non-invasive way to visualize blockages or calcium deposits, which are early signs of coronary artery disease.
But the gold standard is still.
The gold standard for diagnosing the extent and severity of coronary artery disease remains cardiac catheterization and coronary angiography. This is an invasive procedure. A thin catheter is threaded through an artery, usually in the wrist or groin, up to the heart. Contrast dye is injected directly into the coronary arteries, and X-ray images are taken to visualize any narrowing or blockages.
And nursing care around cath procedures is vital.
Absolutely crucial. Pre-procedure, we need to check for allergies, especially to contrast dye or shellfish. Ensure the patient is NPO, nothing by mouth, for several hours. Check kidney function labs, and do a thorough baseline neurovascular assessment of the extremity that will be used for access. Post-procedure care is just as critical. We monitor vital signs frequently, check the insertion site closely for bleeding or hematoma formation, assess the neurovascular status of the limb, pulse, color, temperature, sensation, keep the patient on bed rest for the prescribed time, encourage fluids to flush out the dye, and provide discharge teaching.
What an incredible journey through the heart. We've really covered a lot, from those tiny electrical impulses that keep it all going to the intricate dance of blood flow, pressures, and the amazing high-tech tools we use to understand it all.
Indeed. And I think for you, the nursing student listening, the most important takeaway here is the absolute power of comprehensive assessment. LP's case is a perfect example. Every single piece of information, his subjective complaints, what you found during your objective assessment, his lab results, the ECG findings, it's all part of the puzzle. Your role is to connect those dots, to understand the implications of each finding, and to think critically about what needs to be done first, the priority interventions. It's about seeing the whole patient picture and anticipating their needs before things get worse.
Yeah, this deep dive really hammers home that the heart is so much more than just a simple pump. It's this dynamic, complex system influenced by age, lifestyle, genetics, everything. Understanding its nuances is absolutely paramount if we want to provide excellent, truly patient-centered care. So, as you reflect on LP's case and this wide array of assessments we've talked about today, maybe consider this. How does having a really deep understanding of the normal cardiovascular system actually empower you? How does it help you anticipate and respond to those subtle, maybe but critical deviations you might see in your patients? What further questions does this knowledge spark for you as you get ready to care for individuals whose lives really depend on your sharp assessment skills? Thank you so much for joining us on the Deep Dive. We really hope this has been a valuable shortcut to feeling truly well-informed and maybe a bit more confident for your next clinical challenge. Keep learning, keep exploring, and we'll catch you on the next deep dive.